are there any women who are not good candidates for bioidenticals or hormone replacement therapy? What do they do?
So that's always tough because in the conventional cancer world, somebody would say, "Well, you've had cancer, you should not be doing hormones," right? So in the conventional cancer world, that's a difficult line to cross, and yet the studies don't support it. I mean, um, the there's I've lists of studies to support that appropriately done hormones is actually beneficial, even and protective to somebody who's had cancer, even if it was an estrogen receptor or progesterone receptor positive cancer, or who has a strong family history. In fact, I would say we can appropriately do hormones to help protect that. So my answer to that is probably not. Is there a patient who should not be on hormones? But do I battle that in the conventional cancer world? If I take somebody who just got over their estrogen receptor positive cancer and put them on estrogen, their doctor is going to really be, you know, at my door knocking, and I've given them literature, I've tried to support it. So it becomes a little bit of a fine line to walk. We walk, so we kind of educate our patients both way. Let them make the decision. I give them all the research I can to support my opinion, and I say, hey, go back to your oncologist and talk to them, and let them show you their research, and then see what pans out. But if you side by side put the research, you can support that hormone replacement is beneficial even in that world of somebody who's a high risk cancer or has a previous cancer. Um, so that would be, my answers. Now, we do know one of the things I'll hear is women who have clotting disorders. So they have a genetic issue for clotting, and people say, oh, estrogen increases clot risk. That is only oral estrogen. So there's zero literature that transdermal estrogen, again, you're back to the difference in metabolism by going through the liver. So oral estrogen after liver metabolism will increase clot risk. No studies to show transdermal does that because it's the liver metabolism that causes that. So again, I would never give estrogen orally. That's the problem with birth control pills, right? It's a high dose oral estrogen, and that's why there's a high clot risk with birth control pills. That you can get blood clots and pulmonary embolus. And the other thing oral estrogens do is they deplete testosterone because they increase sex hormone binding globulin, which binds all your total testosterone. So now you have no free testosterone benefiting you. So oral estrogens in general are contraindicated for a lot of reasons, but transdermal's not. So those are the groups I hear from their doctors. Oh, my doctor told me I can't do hormones because I had a blood clot or because I had breast cancer. And I would argue that there's literature to support that that's not true. But my big deal is I will never convince anybody to do anything. I want you guys to make that decision, and what I will do is present the evidence. I'm an avid reader. I've tried to put it all together and say, hey, here's the studies, and I'm happy if your doc wants to come back and show me all their studies and change my mind. Great. It's like I was talking about. If there's a study that I'm not aware of that shows that there's the transdermal progesterone has the same brain effects, then albeit maybe I'll change my mind. But things need to be research based and not just made up because we're scared or things like that.
Yeah, and I'm sure that goes to hormonal replacement done correctly,
Right,
right?
exactly.
We're
Right.
assuming
Yeah.
that because there's plenty of studies I'm sure that could show one way or the other, but it's got to be done
Right, it's
right.
the right kind of hormones, right? Premarin is bad, Premarin is carcinogenic. So, it's the right studies done with the right hormones, done at the right dosing, using things to change metabolism.
Mhm.
Just simply, any of you who are doing hormone replacement, even if you're like, "Oh, I can't afford to do that," you're a metabolite test, simply taking diindolylmethane, DIM, and or indole 3 carbinol, those are the things that are found in like broccoli and cauliflower. They're so beneficial to our health. So the way they work is they're actually, remember that 4-hydroxy pathway we talked about? Well, DIM is a great blocker of the 4-hydroxy pathway. So if you're taking estrogen and taking DIM, you're going to hopefully drive less down that pathway. So anybody who's on, number one, I think just about every woman should be on DIM and maybe man. But that's a good thing to think about too. Is there's ways to kind of do the hormones more safely, even if you're not going to go down the road of you just can't do all this urine metabolite testing. It's ridiculous. At least you can do things that will likely ensure more protective effects.